Hello, everyone. Welcome to another issue of the Brain Discovery series. I'm your host, Ellie. Today, we're going to be doing something a little bit different because I won't just be interviewing Dr. Nedd. We have a special guest today, Dr. Hotz. Dr. Hotz, if you could introduce yourself a little bit, please.
Sure. I'm Dr Hotz, and I direct the Kids Neuroscience Center at the University of Miami. I also wear a lot of hats. Another program that I direct is our concussion program. And actually, I'm filming from our clinic at Lennar, sports concussion, and this is Kester's actual clinic room that he used, I guess, all the years that we were at Lennar. So I guess it's pretty appropriate where I'm filming from, Kester.
Thank you, Jill.
So Dr. Nedd and Dr. Hotz actually worked together for around 30 years at the University of Miami, and they created a brain injury program together. So if one of you want to go in and just tell us a little bit about it and what it took to create that.
So are we going back to 1992, Kester?
Of course, as far back as you want to start.
Okay, so do you want me to start or do you want to start?
Go for it. You got it.
Okay, I'll go for it. So here I am, just a fresh grad, PhD, neuroscience, ready to sort of conquer the world out of Boston. And I came to Miami because they opened up a brand new level 1 rider trauma center the summer of 92. And what else happened the summer of 92 was Hurricane Andrew. So I was here living for about 6 weeks on the beach. And the next thing I know is we're having a Category 4 hurricane coming right to Miami. So I'm going, oh, this is a really nice welcome to Miami. But the Ryder Trauma Center opened its doors and there was, I guess, thousands of brain injury patients at the time at Jackson and the UM system. And really, I think Kester, and he'll tell you in a minute, when he sort of started trying to organize all these brain injury programs. But then when I came, I met Kester and, through Barth Green, who said the guy that really does most of the brain injury in our system is Kester Nedd. He's the director of neurorehab. And so I met Kester, and I guess, they say, everything else is just history now because we developed a whole systematic approach and a very streamlined, comprehensive continuum of care for brain injury across the whole medical center. Kester, why don't you?
Yeah, well, that's, true. It was a time when brain injury in the medical community, particularly in the neuroscience community, there was very little attention paid to individuals with brain injury. In fact, what actually caused us to put this program, the initial program, to what we call the Intermediate Head Injury Program, also known as the IHI. And prior to Jillian coming, we had several incidents where patients would come in to the emergency room or even the trauma center, get treated, sent out, and then go home and have major medical complications, short-term and long-term. And so I recall one time there was an article in the paper where one of the family members complained about the issue when they left. They had a negative outcome. And of course, the entire administration came together and said, let's just talk about this. And this represented the birth of the IHI. It was a mechanism of making sure we capture people that come to the trauma center, people that come to the emergency room, that suffered a traumatic brain injury, and we needed that system of care to be able to treat them right as they came in and also in the long term. It took us a while to develop all of the elements, but when Dr. Hotz came on board, she was the welcome opportunity, a welcome time to change and to help us put this whole system together. So with her energy and us working together, we were able to put a continuum of care for brain injury that was unparalleled. So maybe Dr. Hotz, love to hear you.
I was going to say also, they used to call us the dynamic duo because our personalities are so opposite. He's tall, dark, handsome, very methodical, very analytical, really like thinks things through. And I'm like, short, very loud, and, like to move very quickly. So,
in other words, you were the thunder.
well, yeah, I mean, it was really a good match because the work that we could do in a day, it probably would have taken another, 5 people to do. But we were very organized, very structured, and it was just really the 2 of us, and we had a case manager, Beverly Graven, and we had some fabulous physician assistants that were really, the core team.
Absolutely.
So, what would you guys both say are the key principles that you need to create a brain injury program?
Well, I think it's, depending on like what you're talking about, because listen, we still talk about brain injury of being classified as mild, moderate, and severe. And that's a very gross description. But each one of these programs have different components. And depending on, like, as Kester was mentioning, the intermediate head injury service, this, service really helped out neurosurgery and trauma because it would take these lower level patients that needed to get going in rehab. So the medically surgical type patient that was already like doing pretty well and just needed to get moving with occupational physical therapy and speech therapy and get them, sort of moving on the rehab path. And then the ones that were mild that, really just needed a quick look and a quick turnaround and a screening, and then we would follow them up in a clinic. So, depending on whether it was mild, moderate, and severe, there were different components to the program. So, I mean, later on, I'm sure we're going to talk about how we built the sports concussion, but maybe Kester, if you want to talk about the more severe type programs and the coma type patients and the lower level patients first, I think that'll be the way to go.
Well, one of the things I think we both learned from building a brain injury program was that you needed to have a continuum of care. By that we mean, when you look at the natural history of brain injury, irrespective of severity, all patients go through some change as they move along in the system. In the most severe form, they would actually be in the hospital for a longer period of time, and they would require more services. So it was important for us to, first of all, understand the nature of the progression of the patients. And one of the things I would say from an ingredient standpoint that's necessary in establishing a brain injury program was to truly understand the natural history of brain injury and know how to classify those patients and how to place them in the proper treatment setting. And I think we were very good at that. And one of the things Dr. Hotz, I give her credit for, is that when we set up the system, we were able to say, okay, for the patients who had mild brain injury that came to the trauma center, came to the emergency room, these were the protocols. And those patients would either be admitted for a short period, we will set them up and then discharge them to the outpatient setting. And then we will have a program set up to be able to work this out. And then you will have the moderates that those would stay for a longer period of time. Some of those would end up going to the rehabilitation hospital. And the most severe forms, we'll have them in the intermediate brain injury service, then maybe rehab, then long-term care or home. And so, of course, we were able to work with the social workers, the case managers, and all of those different disciplines, the therapists, to be able to properly classify and place those patients.
So you guys work with a whole team pretty much.
Absolutely.
Right.
In brain injury, you need a team.
Okay, so what would you say were the challenges associated with keeping such a program going?
Well, I'm just going to say one word: administration, commitment, and support. Oh, that was 3 words, I guess. But Kester, you can fill it in.
Yeah, I agree with you 100%. First of all, I agree with Dr. Hotz on this. The first thing you need is what's called political will. The administration of the facility, the institution, must be committed to support this type of program. If you don't have that, it'll never work. And they have to commit resources, they have to commit people, time. The second, I would say, would be, from the administrative standpoint, is having an organized plan. And based on the patients you have, you need to collect data and analyze your program. What are the types of patients that are coming to your center? And what are their needs? And once you have a proper system that's, once you have that proper analysis done, then you could create and design the system with the component parts. The other part is to create a sustainable program that's financially sustainable, that you have a consistent staff. The biggest trouble that I would see in any program is when you have people going in and out. You need a team that's there constantly. When you start having turnover, you lose a lot of the history, you lose a lot of the quality in this regard. Because these patients, you need to see them over a long period of time. So they need to see a common face. They need to see people that they're familiar with when they come back. These patients get very disappointed when they don't have a team that they could identify. There's a lot of trust issues that goes into these type of programs. And the last component, I would say, is to have, other than having great clinical care, would be protocols that would both help the clinical services and the research. Because that's important, given where brain injury is today, having collecting demographic data, doing work on outcomes, and so forth. That makes a really high quality program.
So if you have all of these components, do you think this program could be rebuilt or just done again by someone else, duplicated, I guess?
So I'll tell you this. When we developed this program, I had the opportunity to see one other program in the United States that had a similar focus, and that was the University of Maryland, their shock trauma program. And back in the day, I had the opportunity of going up, and the institution paid for me to fly up and see their program. And they were doing something similar, but didn't have all the components. And at the time when we built this intermediate brain injury program, that component of it, there was not many programs actually seeing the patients from the acute care, from the ICU thereafter. And really and truly, when you think about brain injury from a programmatic standpoint, the area that patients suffer the most, where they're affected in the long term, is that period between the ICU and when they get to the floor, when they become aware that something is wrong with them. And that's the point where we need intervention. And both Dr. Hotz and I recognize this, and that's why we put a lot of emphasis on that program called the IHI, or the Intermediate Brain Injury. Well, we were also in charge of the rehab, the neuro rehab at the time, so we had that under control, and then the outpatient services.
So the other thing I think you have to add here too, and you also said this, Custer, is experienced therapists and clinicians. This is very complicated. You know, brain injury, and the more severe we saw these patients, we really figured out that they needed a lot of intensive management, and 24/7, and some are very agitated, some are very low level, not able to really understand where they're at or what they're doing, some nonverbal. So you really needed a group of clinicians that have experience, and to maintain that, you had to build a team that wouldn't turn over a lot. So I think you mentioned that. The other thing I think you have to have is commitment of space. You need to put these people all in the same place. So you have the expertise, you have the resources, you have the space, whether it's a gym or an occupational therapy, office, or speech offices or neuropsych offices. You need the perfect sort of rehab type space to have these patients in one place, which actually also helps the patient as they see each other and see the different levels that they go through, whether they're using a walker, a wheelchair, or they're able to ambulate on their own. So I think, you need, again, the commitment from the administration. And if you have that, and you have the clinicians, and you have a, leader that has experience to do this, I think you could, replicate it and duplicate it.
Dr. Nedd, this kind of sounds like your private practice.
Absolutely. So basically, that's what happened. I'm now in private practice, and we try to duplicate. One of the challenges in a large medical center that you have is in the continuum of care, the most hospital systems are dedicated to the inpatient, saving the patient's life, getting them through that period, and even some are dedicated to the rehabilitation, the immediate rehab situation. But many of those patients only get treated for about 30 days in the rehab center. But after that, they need all the services. So clearly, it's one of the things we did in the system at the time was to create that continuum of care. Now, it's, the challenge is convincing the administration to maintain that type of service, because hospitals are accustomed to just take care of the patient. Once they're discharged, you're done with them.
Yeah.
With brain injury, you need a program like that. I know, Dr. Hotz, I don't know what your thoughts are on this, but clearly that's some of the challenges that we faced in our own medical centers in trying to maintain that long-term continuum of care.
And that's why you need clinics. You need outpatient programs. You need, this continuum that goes for years. I mean, I think Kester probably has patients that he's been seeing for over 15, 20 years that still come back that were severe, and they follow up with him every year or every 6 months.
Yeah, and that is just like these people become part of your life. You've been following them. Now I have patients that have been following for 34, 35 years. And truly, that is amazing. In fact, one patient told me the other day, she said, Dr. Nedd, I definitely want to die before you. I said, why is that? She says, well, there's nobody else to take care of me if you're not around. And I said, no. Hopefully that would not be a problem that we'll have in the future. And what we need to do is to create opportunities where other doctors like myself could be available to patients as they live through this disability. And that's one of the problems I see in the practice of neuroscience from the brain injury perspective.
I feel like that ties into how TBI is a silent epidemic.
Absolutely.
Yeah.
Yeah.
All right.
And it's just like the number of people, like it takes a village. Like really, it takes like a really committed team to do this well and to really help these patients enter their lives again and have a graduation or get married or, have kids. I mean, we really see all of these life moments with some of our patients that are long-term. And remember, yes, brain injury, 80% is mild, but that 20%, you really become members of their family.
Yeah. And you guys mentioned to me before this that the program was shut down in 2015, right?
Well, let's say this. It was not entirely shut down. Elements of it was closed down. So
if you guys
the
could go into
challenge,
more detail about that a little bit.
yeah, the challenge has been, how do you sustain a brain injury program in the setting of the resource challenges that exist in the healthcare system, and given the competition from other the disorders that you treat. And on a national level, we've seen this as a challenge. And I wrote about this in my book. Many of the programs, and especially from the neuroscience perspective, there are limited programs that actually train doctors and therapists to participate in the treatment of people with brain injury. So across the board, administrators, leaders in healthcare have challenges seeing the value of these programs. And unless you get into these programs and try to understand how they operate and the value that they have in the context of other things, given the financial issues, it's not a program that's like cancer, where you generate high income, or a program like surgery, where you generate high income. Elements of the brain injury, the acute side, is a high income generating for hospitals and health systems. But when you look at the long-term care side, the people see it as a cost center. And so a lot of times, many of the big institutions tend to sort of not support some of these programs, not realizing that what actually happens is in these long-term programs, you actually save costs on the other side. Because what you have happening is patients keep coming back to the emergency room on a regular basis for treatment. But if you solve those problems up front, you educate the family, you get them set up in the right setting. And it's not just a hospital, but that's society in general. It's the allocation of resources from the government, from the insurance companies, and all of those. And that's the challenge as we see it today, is that this commitment on society towards treating people with brain injury is not there. And so you see a lot of ups and downs, programs opening, closing on a frequent basis. And of course, the patients are left stranded. So part of what Dr. Hotz and I have committed our life work to do is to help encourage programs to be built in this. And we're still fighting about this. We're still fighting to get not just our programs, but other programs around the country to look at that model and reconsider how much resources they spend. I don't know, Dr. Hotz, you might have a comment.
Well, and also just the other piece of this is like, who's best suited to really be running these continuum care programs and these comprehensive programs? And, you know, neurosurgery gets the severes because some of them end up in an operating room situation and need neurosurgical monitoring. And then, you know, is it neurology and physical medicine and rehab, neuropsychology, you know, some of these players that now are taking ownership of brain injury rehab. And again, that comes back to your administration, the philosophy and history of, you know, the institution and the administration. And then, you know, everybody sitting down and building consensus of like where everybody fits. And I don't think we had that opportunity in 2015 or even a little bit before that when PM&R came to the University of Miami. You know, we really didn't have that opportunity to sit down and build consensus.
And that's one of the challenges that you face across the country, is that the different disciplines in healthcare sort of compete with each other in a way. And when you lose the sense of collaboration, especially in a subject like brain injury, you know, it's a team approach and all of us play a different role. You know, it's funny, I just spoke to a chiropractor who is doing a lot of work in brain injury, and they're making a contribution. The optometrists are making a contribution. The massage therapists, all of those that we don't think about, the social workers, physical therapy, occupational therapists, the neuropsychologists, all of us play a role in this. And whether you are the psychiatrists, and the challenge is that what we have not done properly in the brain injury world is to cross-train all of our specialists. I mean, right now, if you look at the residency programs in neurology, very few neurology residents get exposed to a patient with trauma, let alone learn about neurotrauma. And in fact, that's true for physical medicine and rehab. That's true for psychiatry. You have to literally do a fellowship, and there are not many fellowships around the country offering brain injury as a postgraduate fellowship from a training perspective. So we think the leaders in these different specialty areas in neurology, in physical medicine, rehab, in psychiatry, and others, pain management, would need to spend more time in culturing these young minds as they develop in neuroscience to pay more attention to brain injury, given the pervasiveness of this disorder.
So you guys have mentioned that it's a continuum of care, right? And that there's many different components and different people involved. Can you guys explain this a little bit more on how it starts and then through it, if that makes sense?
So the actual continuum?
Yeah, so if it starts with the ICU, what happens next, and when they, like, therapists get involved, or chiropractors or social workers, like.
So Kester, if you want to go through that, then I can go through the mild.
Okay, good.
And talk about the mild.
Okay, good idea. So when you come in, you know, we have a saying that goes, rehabilitation starts in the field, right at the point when the EMS picks up that patient. We have to think about outcomes. Our first job.
Kester, hold on. Can I just interject for 1 minute?
Sure, sure.
Remember, you just made me think of something. Remember, we wrote that, I don't know, paper with like coma to community.
That's correct.
Okay,
I remember
go
that.
ahead.
Yes. So the whole idea is that you got to start. The first job that we have is neuroprotection. We got to preserve the brain cells early. And the way you do that is by starting with measures that would cause that person to not have as much damage to the nerve cells in the brain. And that goes through the emergency room. So things like patient safety, something as simple as preserving the neck or not causing the patient to have an ulcer or breakdown while they're in bed, or administering the right drug to manage inappropriate behavior. And that goes to the fact that, you know, sometimes we treat the nurse and the doctors, not the patient. To explaining to the family where they are and what the outcomes are, potentially preparing them. All those are part of that continuum of care. So, and there are different elements to it. So there's the clinical side where you provide the actual care. There's the education. There's the staff development and making sure that the staff is educated about what to do next and when to do, to recognizing, to having protocols and recognizing when there are when intervention is needed, escalation procedures, just like you would if you're flying an aircraft or you planning, any of these engineering feats to accomplish. You need to do the same thing in designing this type of continuum of care. So once you say you have a patient that comes in, the first thing we want to do is to measure how severely injured they are. Take an inventory. What we use something called the Glasgow Coma Scale that looks at the level of functioning. And based on that, that allows us to classify the patient. You know, what's the conditions? Do they have drugs or alcohol on board? You know, what's the nature of the accident and so forth. So from the moment that that patient gets picked up, we are looking at what the outcome is going to be, what resources we're going to need, what's the next step for that patient. Once they get in the trauma center, in the ICU, or in the ER, we are now taking a survey of all of the injuries and coming up with a plan. And that's where that kind of triage process begins. So again, you need the social worker, you need the case manager, you need the doctors and all the other members of the team, the nurses and so forth. So from there, we would then triage patients. So the most severe would either go to surgery or the ICU, or and they would be cared for in whatever way. First of all, it's stabilization, so that we prevent further damage. The goal of initial therapy in the ICU and so forth is, again, neuroprotection. So all of the exercise and that we do in the early stages is to prevent the brain from getting further damage. Realizing from a physiological standpoint that the injury to the brain does not stop when the patient gets into the emergency room. There's ongoing physiological processes that's causing damage to the brain. And so it's really critical to understand what those processes are, identify them. That's how the body compensates, and be able to intervene so that you have a long-term better outcome. From there, we go to the, in our center, we had what's called the IHI, as we pointed out, this was a service that was run by neurologists. That's the medical side. So the neurosurgeons will handle the surgical side, and both the neurologist and neurosurgeon will handle the ICU side. And then we would, in the intermediate injury service, we would prepare the patient for either going to rehab or the community, our home. And that's the moderate and the severe form of the disease. So Dr. Hotz, you're going to talk about the mild.
And then I guess, just to finish up that, they would go to a dedicated rehab bed if they needed, more rehab. But when we started out, we could keep people for 3 to 6 months on a neuro rehab bed. I mean, that really ages us. But now I think you're lucky if you get 4 to 6 weeks for a severe brain injury.
Actually, most of them is 21 days.
Okay, there you go. And then, you got to go home, and then you go to an outpatient program that will offer OT, PT, speech, psychology, neuropsychology, and, some of these other outpatient services. And that's where the patient is for the rest of their life. And we haven't even talked about re-entering work or re-entering school. I mean, this is a whole other group of expertise that, you know, also has to be brought on board. So you can see it's very comprehensive and it takes a lot of people. And if you don't understand that, you're setting yourself up for a broken program that's not going to really be able to maximize the function of the patient. And then on the flip side of all of this, and this is where, you know, we started spending our time and our focus was on the milder patient that, you know, got a really good screening. If they even got admitted to the hospital for 24 or 48 hours, their CT basically was negative, but they were like, as we had a trauma surgeon, a friend of ours in 1992 tester, the patient was goofy. And they you know, they kept them for 24 or 48 hours and then they would go home, and we had a clinic system that we would follow them up in a clinic, and we would be able to advise on any clinical issues, any physical issues. Did they have any academic issues, employment issues? Did they need neuropharmacology? You know, maybe they needed to go back to Baskin Palmer and have some sort of eye exam. So I think, you know, the clinic system was very well developed as well. And then we decided to break off into sports and non-sports. But as they say, that's a story for another day.
Yeah. So Dr. Hotz, you mentioned that you guys were known as the dynamic duo, right? So what was it like working with Dr. Nedd for all those years and from the beginning?
Well, I have to say that because our personalities are opposite, that I threatened to take away his cell phone probably every day. That was part of our working together, because just as busy as he was clinically at and Jackson, he was also helping patients who were already at home and needed services and needed, you know, an MRI, or needed, you know, to come in, or they had a fever, or what medicine. So he was doing all of that. So I think, you know, here was somebody that was totally committed to patient care and helping patients and running this really busy service. So I think it really was a good match, because we were able to really help each other out, and we had some key people on our team that, you know, really assisted us.
And Dr. Nedd, what about you? What's your take on this?
Well, working with Dr. Hotz was amazing. I'll tell you the truth. She gave me the most, when it comes to someone that has the ability to meet goals and objectives, I think she was born with that. What I admired about her, every single day, she will call me at about 6:30 or 7 in the morning, and we had our entire day planned for the day as far as what we were both supposed to do. I always appreciated that structure. And that's something that when I don't have it, I feel like I'm a fish out of water. Because literally, when you run a program that busy, the idea is, how do you delegate responsibility to all the people in the system? How do you deal with administration? How do you, because, you know, in a system like that, you're not just dealing with patients, but you are constantly fighting for resources, fighting to get the system to respond to you and your patients. And if you're not in the forefront, you lose ground very quickly, because there's a lot of competition for dollars in a complex system. And then, of course, one of the things we could have done a little bit more with was research and so forth. And I know Dr. Hotz has taken on that. And today she's actually running a very active and a substantial research program. And I think working with Dr. Hotz, I will tell you, not only has the patient benefited, but I believe the team, from a training perspective, Dr. Hotz both of us spent a considerable amount of time teaching and training. You cannot run a brain injury program without training. You have to constantly update yourself. You have to update everybody in the system. You have to have a team approach. Just about every patient that we saw was a subject to teach. And I think we were successful in training a lot of brain injury. And like when I look out in the community, sometimes I see therapists, I see psychology, neuropsychologists, they all are grateful for the fact that now they have had all these years of seeing patients in a practical sense and getting the training from that. And I think, you know, every time I think about this, I think Dr. Hotz was perhaps one of the most prolific person in, you know, as I could think about in my lifetime in you know, fostering this type of ongoing training program.
So I need to say thank you, Kester, because I feel the exact same way about you. But also, Cuban coffee was helpful because by 11 o'clock, okay, we had already done 15 consults and seen all the patients on the IHI, and then run over to neuro rehab, which was on trauma 4, and rounded on all of them. So, you know, we moved fast, we started early, and, you know, we had a phenomenal group of physician assistants. And I have to say, Jerry, Hazel, Julie, I mean, maybe you're listening to this one day, really, and Beverly and Jasmine, I mean, you know, that was the team.
Yeah, and that was amazing that we had this group of people pulled together and everybody knew what they were supposed to do. It was amazing. And the results you could have seen, you know, I mean, we used to have between 60 and 80 patients in one day that we could see. And not only that, but then we would have outpatient clinics on many days. At one point we had residents, and that, you know, we had residents for a while, and that was very helpful. The residents that's, you know, came on service learned a lot, and, you know, we were able to build a fellowship program. I believe we trained as much as 11 fellows in the time that I was there. And most of them all of them, in fact, have senior positions in neurology, rehabilitation areas. So clearly we did some good in this regard, but very important, I think, for the future leaders in this field to consider that as a major factor. I mean, it's a selfless act to train another doctor, to train a therapist, because it's carrying on that legacy. It's so important. And that's what I'm doing now most of my time. I'm still seeing a lot of patients, but I'm training a lot of other doctors and therapists and others to learn this art so that we can carry this on in the future.
And if I can do a plug for the book, I mean, the book really in black and white, very thoughtfully goes through how the program was built, how it was sustained, and just pearls and pearls of wisdom for the next generation.
Dr. Hotz,
Anna, thank you.
My next question was, what were your thoughts on the book? And I'm sure you have seen so much throughout the years that have influenced the book and everything. So what were your thoughts and your favorite chapter, part of it even?
Well, I have to say that I'm not finished the entire book. I think I'm like in the middle, but I've read bits and pieces from the back part. And I think that, number one, it's just you know, the wisdom, the experience, articulated so clearly that you can like pick it up and use it either as a source book if you're just a young person starting out in the field, or for family members, or for administrators. So I really think it hits for a lot of people, but I also think it was quite therapeutic for Dr. Nedd to write and to put down all of these thoughts that, you know, he's had his entire career into some sort of inventory, catalog that he can clearly think back on the beginning, the middle, you know, the ends of some of the programs and components, and really have something that's succinct to pass on and to sort of reflect on. So I have to congratulate him in being able to do that.
Well, I must say that I'm so grateful that for a little boy that came from the Caribbean and came to the United States many years ago, went to medical school, I could just remember Dr. Scheinberg, Terry Scheinberg, who's no longer with us. People like Dr. Green, of course, Bath Green, Dr. I mean, many of the other leaders, Dr. Walter Bradley, all of those leaders who inspired me to take on this task at the time when when I took this on, there was no one else available to do this in the system. And it allowed me to be creative and to build this incredible system of care that I think hopefully for the years to come, others could utilize this as a model that would help people with brain injury. I mean, I'm on the south side of my career, and certainly I would feel, I feel that it's so important to pass on that knowledge and the experience. I mean, certainly there's research, there's papers that you could write, but nothing beats, after having, well over 250,000 patient encounters in that system, it's a lifetime of experience. And my thought was, how do I best communicate this knowledge to the next generation of healthcare providers and professionals? And that's why the book Concussion, TBI from Head to Tail came into existence. So, and Jill, I have to tell you, thanks, because you have always motivated me to write this book, and always appreciate your contribution over the years. I'm so grateful for you as a partner, because you are truly the inspiration for me every day to continue in this struggle. And you've been there to support me 150%. And I know now that you are running this major program, which I know we're going to have another discussion on, which is the concussion clinic at the University of Miami. I really congratulate you on this amazing work that you've done. And I think one day I look forward to seeing your memoirs and your own book.
I have to do it too? I have to write a book too? Okay, it's a challenge.
Yes, that's part of your obligation to the world.
Well, listen, it's really rare to find somebody with Kester's ability, especially in the United States, just the experience and the knowledge. And I used to laugh and tell people, just come and see Dr. Hotz, because really any complicated, sort of problem, somebody who's 5 years out from their injury, somebody who's got a lot of problems, Kester has a way of looking at these people, and first of all, they're human, right? So treating them like a person. It doesn't matter if you're a bank president or you're a plumber or you're somebody that, works at a pool. He treats everybody the same. And I think that's one of the things has made Kester so great as a clinician, because he really wants to help everybody, and he really tries to and spends a lot of time doing this. And so I used to, we used to laugh and call him, well, come and see Dr. Hotz, because the most complicated cases, he was able to improve somebody's outcome, whether it was 5 or 10 years out. And I think this is about listening. He listens to people. He listens to what they have to say. And then with the experience, he's able to pull something together, his magic, I used to call it, or, he had this combination of drugs that he knew, well, this is going to work on stimulating them. This is going to work on sort of, their anxiety. This is going to work on their headaches. And you need to see thousands of patients to do that. And so for him to share all of this with the rest of the world, I think it's just, fantastic. And really, you find these people, once in a lifetime. So I think the world is lucky to have this all written down now.
You guys,
you
guys both talk about each other with such love and admiration, and it's so nice.
Well, that's what happens after 30 years.
Yeah, it seems so.
You either hate the person or you love the person.
Yeah. We're like family, I'll tell you this. We are all like family. And all the others that have worked with us, which Jill mentioned their names, we still all stay in touch. And it's just amazing the amount of work that this group has put together. And what would do my heart great is to see other programs develop this type of integrated continuum of care to treat people with brain injury, because this really worked for us. And hopefully this next generation of administrators, this next generation of doctors, financiers, policymakers would really look at brain injury different, because this disorder is more common it really strikes at the humanity when you think about, how common brain injury is and the impact it has on society. A lot of persons out there that we diagnose with psychiatric disease who have trouble with the law, kids who have trouble in school, and all of these individuals, people that just feel unhappy. What they don't realize many times that they had a brain injury when they were a child, or a concussion. They may have gone to the ER, and either the parents or the doctors in the medical system never paid attention to it. And that's where this is at. Now we're realizing that brain injury has had more of an impact on society than we previously thought. And so if we could, in our small way, influence people in the world to really pay attention to this disorder, we think we will make a world of difference.
And this, one more thing I'm thinking about is that, Dr. Nedd doesn't need a lot of sleep, right? So he sleeps like maybe 4 or 5 hours. So all that time goes into treating patients, and the generosity that he has, whether you're a medical student, you're a resident, you're somebody from like another country that calls him or sends him an email and says, can I come and shadow you? Every time I get into clinic, there was like another group of people there that somehow, some way, he found, or they found him to come and learn from. And I couldn't, say no, or I couldn't, say, we can't really do this, because, he was just so generous with his time because he wanted to teach the next generation and mentor them. So, just to spread all of this information. And so I guess, again, I'm back at the book saying, well done, Hester. It's in black and white. Now we can send it to all those students for all those years that came here for like a month or 2 months to follow you. Well, they definitely need to get the book.
True story.
I still don't understand how Dr. Nedd had the time to write this book with his busy life, but somehow he did.
Oh, don't you worry. Every week I said, okay, did you get that chapter done? Did you get that done? Did you get that done? And let me say, to his credit, he went home like at midnight, and I think for 2 hours or 3 hours, he worked on this. So I guess you only got 3 hours of sleep, Hester.
Yeah. Well, yeah, it took a lot to write this book. And sometimes in the middle of it, in fact, I had to rewrite this book 16 times in order to get it to the level that.
But you got it right. You got it right.
Yeah, it took a lot of time.
I'm waiting for the next book.
It's on its way.
Okay.
Yeah.
I think you guys said it right in the beginning that you are quite the dynamic duo and seem to be the perfect storm.
Yes, at the same time.
We're still storming. We got some ideas. Stay tuned, right, Hester?
Absolutely.
Okay.
We do.
All right. Well, that's going to be the end of this issue, but stay tuned because we will have another one, everybody, where we are going to be discussing the youth sports concussion program at the University.
Thank you.
All right.
Stay safe, everybody.
Bye.
Thanks.
Thank you.